Yeah, brilliant. So, someone who can shed more light upon this topic is our guest at hand. We have Dr. Sarju Patel with us. Peace be upon you, Dr. Patel. How are you doing this morning?
I'm well, thank you very much. And thank you for re-inviting me onto the show.
No, a real pleasure having you on the show with us, Dr. Patel. For the benefit of our listeners, Dr. Sarju Patel is a Reader Associate Professor at Cardiff University School of Medicine, where as Director of Year 2, he plays a key role in the design, delivery and assessment of the undergraduate medical curriculum. He is also co-chair of the Medical Schools Council, EDI, Alliance, and is currently leading the development and a national anti-racism guidance for UK medical schools. With over 2 decades dedicated to education and inclusion, he is committed to building dialogue across divides and inspiring people from all backgrounds to see higher education as a place where they belong and can flourish. Amazing stuff. Again, a real pleasure having you on the show with us, Dr. Patel.
Thank you.
Let's get straight into this. As a leader in medical education at the Cardiff University School of Medicine, you work with students from many cultures, faiths and backgrounds. And from your experience, where do future doctors most struggle to truly understand difference, not just tolerate it, and how could the Islamic idea that diversity exists so we may know one another reshape medical training?
I mean, within my context, obviously, I'm dealing with medical students specifically. So in my view, when I see the medical students come in, they really struggle with tolerance. They're very tolerant. I think today's youngsters are much more tolerant than I was, for example, when I grew up, and I grew up in the 70s and 80s. The bigger challenge for them is to go from tolerance to actual acceptance and understanding people's lived experiences. And that's where the probably gap lies a little bit. For me, the first step is for our students to recognise their own biases. So we all have them. It shapes what we do and how we do it. And it's specifically based on our cultures, our faiths, our values and assumptions of our families and communities. And everyone looks through the world through their own lens of culture, faith, gender, and prior for us, healthcare workers and professionals, our prior experiences of healthcare. And if you don't recognise those lenses, it means that students think that their norms, what they see and how they see the world, is everyone's norms, or that their norms are the most important ones. And in practice, that means they assume that everyone experiences the world the way they do, and that the way they interpret the world is the only way you can interpret the world. And it shows up in a couple of predictable ways. So they treat everyone the same, and they treat everyone the way they expect to be treated. As students often equate fairness with sameness. So by treating everyone the same, they think they're being fair. Well, what they forget is that everyone is different. We have different experiences. We have differences in trust. We have stigma. We have language barriers. We have family dynamics and practical constraints that limit what we can do. And that means that though they're treating the treatment might be technically correct, actually what you do is you forget that this is a person, and the treatment can become ineffective because you've forgotten the human element in this. Secondly, they can retreat to biology when they're unsure. So when differences feel awkward or unfamiliar, students lean hard on guidelines and physiology and sidestep social and psychological dimensions of illness. Yet those dimensions are often the most real barriers to care and whether someone can actually engage in treatment, disclose concerns, or follow a plan safely. The third one is stereotypes. They use we've seen a lot of people, communities are stereotyped in who they are and what they are, and this actually limits what people future clinicians can do. When we stereotype groups, we basically flatten them into individuals and template everyone to be the same. And that means that we might miss again the person in front of them. Because just because I'm Asian doesn't mean that I'm not also British, and it doesn't also mean that I don't have my own sort of values and beliefs and actually interests, and my background doesn't dictate everything about me.
Of course.
And the final one is trust. Students may not fully appreciate how trust shapes what patients disclose. Patients will fear judgment, or who experience discrimination, may hold back key details, appear to agree when they don't, or disengage quietly. For some ethnic groups, and we've seen in the past, mistrust is also reinforced by historical and contemporary experiences of exploitation, unequal treatment in healthcare, and this is where treatment can feel unsafe.
Mm-hmm.
So biomedical education and training embracing the idea of diversity exists so we know one another, it will shift diversity from something to manage into a clinical duty and to know the patient as a whole person. That stance encourages discipline, curiosity, deeper listening, shared decision-making. So treatment plans are tailored to the patient's beliefs, priorities, and barriers. And by doing so, outcomes improve because care fits the person, not the disease.
Amazing stuff.
Thank you very much for that, Dr. Patel. Thank you very much for that. In Islam, as in many other faiths, human dignity is equal for everyone, and true worth is measured by character and righteousness, not background. And now, in healthcare settings where unconscious bias can directly affect patient outcomes, how can educators practically train students to see people first before labels, accents, or assumptions?
So there's no easy answer to that. But I could probably look at it through three layers or three sort of principles. The first being by selection. Mm-hmm. So currently we admit mostly on performances, but we should look at the values as well and not just grades.
Yeah.
So can use this by when we use our multiple mini interviews, use situation judgment style tasks and test respect, fairness, listening, and accountability within these tasks. So we include station designs where applicants must respond to differences, challenge a biased remark, or negotiate a care with a patient's values. This does not guarantee character, but it reduces the risk of selecting people who cannot live the principles of equal dignity in practice. The second is by exposure, so making diversity normal, not occasional. So if students only meet diverse patients in rare, high-stakes moments, stereotypes harden. So however, if we build constraints by putting longitudinal contact with the students in community placements, mental health units, refugee and asylum healthcare services, as well as disability services, and faith-aware contexts, then we strengthen that within, and we strengthen that within academic learning sessions. We can help students see variation within groups, and then that labels predict very little about an individual, and this should hopefully help them develop into compassionate clinicians. And by having these repeated encounters, we can embed these attitudes and behaviours that protect dignity and which are not forgotten when we're stressed or pressured. And for me, one of the biggest ways of doing this is looking at the hidden curriculum. So for me, it's role modelling. So me as a role model for my students. So we should address our own biases and assumptions. We need to recognise and understand that what we tolerate as educators, how we behave as educators, and how we treat others as educators, students learn from. Yeah. So we need to model on that and say, do as I do rather than do as I say.
Yeah.
And the final limitation, one big limitation, is that we cannot train compassion into people. Education can only shape expectations and build skills, but the principles of human worth and character matters is something that's either in you or isn't in you and can be reinforced by education.
Yeah, brilliant. Just finally, you help shape the next generation of doctors and clinical leaders. If you could redesign one part of the curriculum to better prepare students to serve deeply diverse communities with dignity, empathy and cultural awareness, what would you change, and why is it that especially needs urgent today?
I'm actually very, very fortunate position as being one of the year leads and being one of the leadership team within the medical school at Cardiff University. So I have a bit of autonomy in redesigning my year, particularly. So the things I'm doing is I'm embedding change within my year and looking at health inequalities and inequities as a continuous thread across the entire year, rather than treating as an isolated lecture or optional resources for our students to look at. So how does that manifest practically? I have asked each of my leads in my year to weave these themes into their core teaching And they've asked them to use lived experiences, patient stories, structured self-reflection as part of that. That means case-based learning that includes social context, not just pathology. Teaching highlights that highlight key themes that I want to push through regarding students, expecting students to examine assumptions, language, power dynamics, and how to practice with dignity. Why is that important right now? So we saw during COVID how mistrust, particularly in ethnic groups, impacted their health.
Mm-hmm.
So we saw lots of ethnic groups not get vaccinations. And there's a lot of talk about why that might be. But one of the biggest things we forgot is these are people, and there's a history behind their trust.
Mm-hmm.
And so if students only learn many things through a biochemical lens, they may unintentionally miss what is driving illness and what is blocking care.
Mm-hmm.
So embedding these principles and making them culturally aware as part of the clinical competence, it helps them graduate into delivering fairer and safer, empathetic care for everyone from day one. And for me, particularly right now, if you look at the world right now, it is a not nice place for people of colour.
Mm-hmm. Mm-hmm.
It is quite a toxic and quite a harsh place. For me, I did a piece a while ago with the BBC regarding, I'm seeing reminiscence of the 70s coming back into the world.
Mm-hmm.
Sound like me.
So we've got to look at that aspect and challenge that narrative.
I agree with you. I think prejudice has just gotten a bit more academic, institutionalized, whereas in the 60s and 70s, I think it was in our face. We knew it was the thug. We knew it was in our face, whereas now it's become a bit more deep-rooted.
Our society is so divided that a couple of years back, I remember I was in a supermarket and this old lady walked past me and she was clearly speaking in Gujarati on the phone. And this another man who was some sort of European, maybe Eastern European, who walked past. Mm-hmm. And he mimicked what she was trying to say to whoever she was speaking on the phone in a very derogatory way. And then he looked at me and smiled and just said something in his language and walked off. And I was like, how divided our society is that two immigrants from two different countries are, or at least one of the two immigrants is being derogatory towards another immigrant just because he thinks he's probably superior than her. And that horrified me.
Just to add to that, I think people are becoming braver now in what they say to people. So I've had instances where, I'm a leader in a medical school and I've been told to my face, it's okay for white people to say racism doesn't exist because for us it doesn't.
Because but then this is the result of Brexit when the T-shirts came out that it's okay to be racist.
Yes, and obviously, we've got certain leaders in the world right now that actually exemplify racism.
Of course, populism is yes. Doctor, thank you so much for giving us your time this morning. I wish you a fantastic day ahead. May peace be with you, sir.
Thank you so much for inviting me again. Thank you so much.
Thank you.
Thank you.
Bye-bye.